actually want to bring this down to the health plan level. And I want to talk to you about how a special needs chronic disease health plan can participate in this process, how we use our health information technology to serve a very special population. So some key facts about our company and our health plan is that we are the largest Medicare Advantage health plan focused on the care of chronically ill beneficiaries. So we are the largest, what is called a CSNP, Chronic Illness Special Needs Plan. Our membership currently is 111,000 members, and 85% of those have the chronic diseases that we've been talking about here today. Diabetes and heart failure, we are licensed to care for patients with diabetes and heart failure. We also have a DSNP, which is dual eligible, a special needs plan that serves dual eligible Medicaid and Medicare eligible beneficiaries. 76% of our members have diabetes and 45% have heart failure, 46% have heart failure across the population. So that's not only in the chronic SNP but also in the dual SNP. So we have a lot of chronic illness burden in this population. And currently we're serving members and we're targeting members in 6 states. So we are working out of Arkansas, Georgia, Maryland, Missouri, South Carolina, and Texas. So we're in 6 states, and next year we'll add 6 more states and we'll be in 12. The majority of our members join us from fee-for-service Medicare, and we all know that in fee-for-service Medicare, generally care is not coordinated as it can be within a special needs plan. Another key point to our work is that 75% of our members are rural. So we're not talking about members that are, or beneficiaries that are concentrated in urban areas. We're talking about people that are living way out in the counties, way out in the rural areas, down a dirt road, folks that are in medically underserved communities that we're touching. Low health literacy, 3 and 4 do not have a high school education. 61% of our members live at or below the poverty line. 1 in 4 are clinically depressed. And about 45% are permanently disabled, but the remainder of the population that are not permanently disabled, the average age is 76. So you get the picture of a very elderly, chronic, disabled population living very dispersed in rural areas in these states that we're serving. They have an average of 13 different doctors, yet 1 in 3 are considered medically homeless. They can't even identify for us a primary care physician. And then when you talk about medication management, which is hugely integral to what we do, our members take an average of 11 to 14 chronic medications per month. So huge numbers of medications to manage in this rural, elderly, very sick population. Next slide. So Senator Whitehouse and Dr. Thorpe actually have talked about addressing Medicare's challenge and of the cost burden. And you can see at the right-hand side of the curve, you have those that are chronically ill that are using the majority of our Medicare dollars. And the prevalence of chronic disease at that end of the curve is just huge. So I want to talk to you about our health information technology system, which is called XLCare. And this has actually been in development for the past 7 to 8 years, so it's gone through lots and lots of different iterations, but it is proprietary. It has been developed by our company, and I'm going to talk to you about some of the programs that we have and that we bring to these beneficiaries, but I have to tell you that none of this could work if it wasn't for our health information technology system, which is the center of everything that we do and coordinates all the information that we have. So within health plans, I can tell you that one of the great things about health plans is that we have lots and lots of data. So we have data from our hospitals where our patients are hospitalized. We have data from the outpatient clinics where they go. We have pharmaceutical data. We know who's accessing what drugs and what their claims look like and what their drug spend looks like. We have lab data. We have assessment data. And we have lots and lots of people that are working with our patients. So we almost have data overload. So what are we going to do with all this data, and how are we going to use it at the point of care so that our clinicians can create plans of care and work to help these chronically ill patients. So as a special needs plan, I can tell you that at the core of what we do is an interdisciplinary care team. So we not only bring to the patients physician care, but these beneficiaries, given the demographic that I've just talked to you about, have other needs. So we are talking about practitioners like social services, like social workers, dietitians, nurses, nurse practitioners, behavioral health specialists. All of these are interdisciplinary care team that we bring to the member. Pharmacists is another huge piece of our program that we'll talk about. But again, we need to have a health information technology that we can put in the center to manage all of this. And when you're talking about rural patients and practicing throughout different states with small pockets of members in different areas and not around one large clinic, we form what we call a virtual care team. And in order to have a virtual care team, you have to have a health information technology that houses all of this and helps the clinicians at care for these members. XLCare helps us to do that. So these are some of our programs. I can tell you that you have 111,000 patients coming into your health plan. How are you going to stratify them, and how are you going to know which resources to bring to bear on these patients? The first thing we do is stratify our population. So based on all the data that we have, we can look at things like their HCC scores. We can look at the predictive modeling that we have built into our health information technology to look at who are the most frail amongst our population and what kind of care plans need to be developed. Every member, when they're enrolled with us, gets a house call. So if you think about the fact that they see maybe 13 different physicians, but they don't have an identified primary care provider when they join. So what we do is we use nurse practitioners and physicians to go out into the community to see them in the home, to do a complete history and physical and health risk assessment right in the home where they live, to meet their caregivers and to look at their environment. So that is a very large part of our program. Those practitioners actually take a tablet with them, and that tablet houses, they can record the H&P and the problem list that they develop upon seeing the member, and that information feeds back into our XLCare system that helps to populate what we're going to do for the patient next. Another huge piece of it is medication therapy management and our pharmacist program. So we employ clinical pharmacists in our company that their entire job is to look at the data, look at the plan of care, find out what the claims information looks like, how many chronic medications are they taking, is there interactions between the medications that they're taking, what does their adherence look like, because we have pharmacy claims, we know how often they're filling their medications, and to call beneficiaries, to talk with them on the phone, to talk with their caregivers, and give them one-on-one counseling regarding the meds that they're taking. Our MedAssist program looks at untreated conditions. So our health system, our health information technology system, because it has all the claims data, we can tell that there may be a claim from a hospital for a certain chronic illness that is not being treated elsewhere because we don't have follow-up claims, for instance, in the outpatient setting. So we have a team that does nothing but mine the data, looks and sees, okay, what are the chronic illnesses that this member has, and are they being treated? And if they're not being treated, let's get that member into a primary care or a specialist that can help to treat that condition, and then follow it over time because the data continually comes into the system. And then finally, we do have very strong care coordination via our nursing programs, our utilization management, and our care management programs. The care coordinator, the care manager, really functions as the quarterback in getting that information where it needs to go, getting the information to the primary care doctor from the house call or from the pharmacy programs, getting the information to the specialists, collecting things like discharge planning and discharge instructions from hospitals and making sure that those instructions get to the providers that are caring for the member. We also specialize in an end-of-life program, a palliative care program that looks at those folks that have chronic illnesses that are at the end of life and what supports do they need. And again, it's our health technology that supports all of this.